Thank you and welcome. As much as I would have loved to have been at the meeting in person, unfortunately, I was unable to attend. Radiographic classification is one piece of the puzzle in determining clinical management of individual cases. Is there any literature out there that can provide guidance to managing various forms of bony changes after cervical disc replacement? In fact, members of this expert panel did perform a literature review, and results are in the process of publication. The short answer to the original question of literature providing guidance to management of bony changes after CDR is no. As part of the proposed taxonomy and classification of bone loss and cervical disc replacement, these are the categories of bony changes of interest and relevance: end plate rounding, cystic erosion adjacent to the end plate with diffuse margins, cystic erosion adjacent to the end plate with sclerotic margins, cystic erosion not adjacent to the end plate, radiolucencies, and heterotopic ossification. Some of the other components of the classification system that have clinical relevance includes spondylolisthesis and subsidence. Based on input from the large joint arthroplasty literature, as well as experts on this panel who have extensive experience in large joint arthroplasty, most concerning radiographic bony changes are cystic erosion adjacent to the end plate with diffuse margins and cystic erosion not adjacent to the end plate. In addition to the radiographic changes, when it comes to the clinical management of these patients, clinical presentation is paramount. So, what are some of the key clinical complaints? Neck pain is one of them, but this is less concerning unless it is rapidly progressing. Arm pain is more concerning, especially if it is in the pre-op distribution, indicating possible reoccurrence of compressive pathology at the index level. New symptoms of progressive dysphagia indicative of reactive soft tissue swelling or possible implant migration. Constitutional symptoms indicative of possible infection. Progressive nature of these symptoms is very important. In assessing bone loss and its progression, serial radiographs are a must. Changes in implant observations such as core height loss, sudden increase in implant mobility, or incongruous prosthetic components should raise concern and initiate further workup. If further workup is indicated, fine cut CT scan to assess bony changes is the recommended next step to look at possible infection versus debris-initiated bony changes versus failed osseointegration. Metal suppression MRI has limited utility in the assessment of bony changes, but can provide some useful clinical information regarding soft tissue changes surrounding the implant. Serologic workup for infection markers such as CBC with differential, ESR, and CRP should also be included. If some of the less concerning bony changes are noted on plain radiographs, consider a shorter follow-up period. Observation of these bony changes does not or should not lead to surgical action. A good example of this includes end plate rounding. Let's run through some of the case examples. So in our first case, we have a 42-year-old male who underwent cervical disc replacement at the C5-6 level with M6 prosthesis approximately 5 years ago. He currently has no neck or arm symptoms. His current NDI score is 6. Here are the serial radiographs starting with pre-op to immediate post-op to 6 weeks, 3 months, 6 months, 12 months, and then annually thereafter up until 60 months. Let's pick out some of the key time points and zoom into the operative segment to get a better look at what is taking place. You can see from the post-op to the 3-month, there is already some end plate rounding along the superior anterior bony end plate. This process continues at 12 months, has stabilized at 36-month follow-up, and similarly shows no further progression at 60-month time point. This type of end plate rounding is commonly seen with all prosthesis and should be treated as benign. Second case is a 78-year-old female with a neck and severe right, greater than left radicular symptoms. You can see here her pre-op x-rays with advanced degeneration at the C5-6 and C6-7 levels, followed by intra-op final images showing great height restoration and well-positioned Mobi-C implants. At her first post-op appointment, her pain is completely resolved, but she has very obvious C7 superior end plate failure and subsidence. Decision was made to watch this, but instead of routine follow-up at 3 months later, she was asked to return 3 weeks later. Here's her 3 weeks later at her 6-week post-op follow-up, still asymptomatic and stable subsidence. Here's her follow-up at 6 months with no symptoms or radiographic progression. Then all the way out to 2 years where she has gone on to fuse that segment with no clinical sequelae. Here's our third case, which is a 55-year-old female with neck pain and left arm pain. She had C5-6 and C6-7 degeneration, along with herniated disc along the left side. She underwent 2-level Prestige LP disc replacement at both levels approximately 6 months ago. She's feeling well. She's riding horses. She has still some residual left-hand numbness in the C7 distribution. And if we look at her radiographs, at post-op day number 2 compared to 4 months post-op, especially if we focus in to what's going on just anterior to the bony end plates, we can see anterior vertebral bone loss both at the C5-6 and C6-7 levels. This is end plate rounding, which I previously mentioned. This is a case that is being observed closely. She is asymptomatic, and with this radiographic finding, she will likely continue to do very well. This next case is a 40-year-old female with 2-level ADR in 2016. She did very well initially with relief of her radicular symptoms. Her neck pain improved but never completely subsided. Here are her pre-op x-rays showing kyphotic alignment in the neutral lateral, but excellent, almost supraphysiologic motion on flexion extension views. Here are her intra-op final fluoro spots showing well-sized and positioned Mobi-C implants. This is her 4-week post-op x-ray showing perhaps very early hints of anterolastesis on lateral flexion views at the C5-6 segment. Clinically, she's still very satisfied. Here are her 1-year post-op x-rays showing more pronounced anterolastesis at the C5-6 segment on lateral flexion view. Clinically minimal persistent neck pain, but again, no radicular symptoms. She still continues to be quite happy. Here are her 4-year post-op x-rays with neck pain progressing and reappearance of the C6 radicular symptoms and more magnified anterolastesis at the C5-6 segment on the lateral flexion extension view. Here are the same lateral serially radiographs placed next to each other for better demonstration of the progression of her anterolastesis. At this point in time, decision was made to move forward with revision at the C5-6 level. She was revised to ProDisc C at the C5-6 level. Here are her 4-week post-op x-rays. And here are her 1-year post-op x-rays showing excellent motion at both segments. Her radiculopathy has subsided, but the patient still has some of that baseline neck pain that has persisted from day 1. Still, she's quite happy. So the next steps include clinical management algorithm that is aligned with the radiographic classification system. Longer-term prospective studies would also be performed to validate the algorithm clinically and histologically. In the meantime, as I mentioned previously, members of this expert panel have completed a literature review on this topic, and this is in the process of being submitted for publication. Thank you very much.